Hi everyone. I just want to start first by saying thank you for understanding that I had to cancel our class last night. Thank you for your positive thoughts and your prayers about my mother-in-law. She's home now. She's resting comfortably. The surgeon's pretty confident that the lymph nodes were negative. Of course, the pathologist is going to look at them to be sure, but they're sure that she's stage 1 with no lymph node involvement, so hopefully the mastectomy will be the only treatment that she has to undergo. So I do appreciate your support and understanding in that. I'm going to record these by chapter or by topic, so there will be 4 or 5, sorry, I can't remember now, that will be uploaded, and then you can watch them in brief sections, and then review them, rewind, pause, whatever you need to help you study. While you're going through them, if there are any questions, of course, you know how to get a hold of me, either text or email or call me, especially when you're studying for the HESI. So this, first of all, we're going to talk about bipolar and related disorders. The bipolar spectrum disorders are characterized by 2 opposite poles, mania and depression. These are the different types of bipolar disorders: bipolar 1 disorder, bipolar 2 disorder, cyclothymia, bipolar unspecified, and rapid cycling bipolar disorder. Okay, so if you take a look on page 280, it lists the spectrum of bipolar disorders. By definition, a bipolar disorder means that the patient has had at least one episode of persistent or elevated, expansive, or irritable mood, which of course is mania. With bipolar 1 disorder, the patient may experience psychosis along with their mania, and they may require hospitalization. With bipolar 2 disorder, the patient experiences hypomania that alternates with at least one major depressive episode. Psychosis is not present in bipolar 2 disorder. With cyclothymia, there are hypomanic episodes that alternate with minor depression, at least 2 years in duration. Then unspecified bipolar disorder is disorders with bipolar features that don't fit into those other 3 categories. Now, rapid cycling bipolar disorder means that the patient has 4 or more mood episodes in a 12-month period. Rapid cycle bipolar disorder used to indicate more severe symptoms, but now it is more specified with the number of cycle alterations or cycles that they have in a year. Rapid cycling can occur with either bipolar 1 or bipolar 2 disorder, and then that will be specified in the diagnosis. There can also be mania or hypomania with mixed features, which is when the patient has a full bipolar hypomanic mood that displays at the same time depressive symptoms. For example, increased activity or agitation, along with feelings of worthlessness, is suicidal ideation at the same time. As the slide says, the distinction between bipolar 1 and bipolar 2 and rapid cycling or mixed mania specifiers is crucial. So when you see the diagnosis, it will be specified, for example, bipolar 1 disorder with hypomania with mixed features. Or it may be bipolar 2 disorder, rapid cycling. Okay, so this was an activity that we were going to do in class, differentiating between unipolar depression and bipolar depression. You should explore those topics on your own. They are listed on page 281. Excuse me. The unipolar depression includes sleep disturbances such as general insomnia, difficulty falling asleep or waking repeatedly, loss of appetite, diminished interest in eating. The patient may be agitated, and episodes often last longer, whereas bipolar depression Onset is usually much younger, around early adulthood, 18 years of age. Disturbances in sleep manifest as hypersomnia. They're very sleepy. They have excessive tiredness with difficult morning waking. Change in appetite often takes the form of binge eating and cravings for carbohydrates, and is often more marked by psychomotor retardation. These patients of bipolar depression are at a higher risk of abuse and suicide than those with unipolar depression. The theories behind bipolar depression, biological theories include genetics, which twin, family, and adoption studies strongly support genetics, but not one gene, or there hasn't been one gene that has identified. Rather, there has been multiple genes that contribute to the expression of bipolar disorder. Neuroendocrine theory supports there's a disruption of the hypothalamic pituitary adrenal functions axis that modulates the stress response. And the neuroanatomic theory is that there's a ventricular enlargement, cortical atrophy, and sulcal widening, which is seen on an MRI. Psychologic influences and cultural considerations. Stressful life events can trigger symptoms of a bipolar disorder. And then, of course, cultural differences and beliefs can complicate the issue. Mania exists on a continuum, and this is illustrated or described in Table 16-1, page 285. That's an important table that you'll want to review. There is hypomania, acute mania, and then at the very peak there is delirious mania. And you'll see on that continuum a wide range of increasing behaviors, speech patterns, and thought processes. So taking a look at Table 16-1, you'll see that there's different signs and symptoms that are described there, including communication, affect and thinking, and physical behavior. So for example, in hypomania, the person talks and jokes incessantly. He or she is the life of the party, and then gets irritated when they're not the center of attention. Whereas in acute mania, their mood may change suddenly from laughing to anger or depression. We would label them as labile. And then when they have extreme or delirious mania, they'll be totally out of touch with reality. In terms of affect and thinking, with hypomania, they're full of pep and good humor, feelings of euphoria and social ability. They may show an inappropriate intimacy with strangers. And then in acute mania, their good humor gives way to increased irritability and hostility, short-lived periods of rage. And then with extreme or delirious mania, they become destructive or aggressive and totally out of control. And then you can continue to read through that table. That's a very important table for you to differentiate between hypomania, acute mania, and then delirious mania. Patients who are in delirious mania will need hospitalization and drug therapy. After mania, or as they're coming down from that manic episode, they often are startled and confused by the shambles in their life and the aftermath of that mania. Approximately 50% of patients in the manic phase have psychosis. Grandiose delusions are very common. For example, the person may think that they have special powers or special abilities. You'll often see religiosity in those patients. Other times the delusions may be paranoid in nature. They have flight of ideas. They're not unable to focus on any particular thing. And then their cognitive function is also impaired. Nursing diagnoses for these patients can include risk for violence, defensive coping, ineffective coping, disturbed thought processes, and situational self-esteem. Outcomes, this slide should say outcomes. Apparently I got tired when I was typing that word, outcomes. In the acute phase, outcomes or goals of treatment are focused at medical stabilization, maintaining the patient's safety, and helping them to meet their self-care needs. For example, they need to stay well hydrated. They may need to maintain stable cardiac status, maintain or obtain tissue integrity, so the absence of infection or absence of untreated cuts or abrasions. They need sufficient sleep. They need to demonstrate self-control with the help of staff or medications, as evidenced by the absence of harm to self or others. And then another goal should be that they make no attempt at self-harm or harm of others. In the continuation phase, the patient and family need to or will attend psychoeducational classes to discuss a variety of topics and give directions to the patients and families. They will need support groups or support therapy. The patient may need cognitive behavioral therapy. And then they also need communication and problem-solving skills training. During the maintenance phase, the goals are focused on preventing relapse, reintegration into society, medication compliance, and increased social support. Communication for a patient, or communication with a patient who is manic, you need to display a firm, calm approach. However, that does not mean abrasive or confrontational. It needs to be matter-of-fact but respectful at the same time. Express short, concise explanations or statements. The patient does have the right to know what's going on or what their situation is. So, for example, you can go in their room and say, "Joe, it's time for lunch. You know the rule is you have to eat at the table." And then that also helps to avoid manipulation. You have to remain neutral. It's important to remain neutral while you're talking to the person because they are very manipulative, and they can also be very delusional. Maintain consistency. So all of the staff members need to communicate with the patient in the same manner. The same limits need to be enforced. The same rules need to be enforced. Conduct frequent staff meetings to agree on the approach and limit setting. Hear and act upon legitimate complaints. So, for example, if the patient complains that their food is too cold, it's okay to heat it up for them. If the patient complains that they need more covers on their bed, it's okay to provide more covers. And then firmly redirect their energy. So if you look at table 16-3 in your book on page 290, it has a list of interventions for acute mania focused specifically on communication. And it includes the interventions that I have listed here on the slide, but then it also goes a step further and provides the rationale, or the why do we communicate with the person that way. So, for example, firmly redirecting the energy. Distractibility is the nurse's most effective tool during the patient's manic phase. So, for example, if they're fixated on one specific thing, be it exercise, for example, it's okay to allow them 30 minutes of exercise per day, but then refocus that energy on something that's more productive. For example, it may be crafts or some other kind of recreational therapy. sorry, I'm going to back up here. The other table, 16-4, includes interventions for the acute mania, safety and physical needs. Safety and physical needs are very important for the patient who's in mania, and table 16-4 talks about structure in a safe milieu and how important it is to maintain a milieu that is safe for the bipolar patient who is going through mania. They need low stimuli in the environment, which means no noises, no bright lights, no loud people. Sometimes you will see, if you go into an inpatient psychiatric facility, that the milieu is often very sedate, very calm, very boring, we would say, and that is because we don't want to overstimulate those people. Nutrition is very important. Sometimes it's important to give them those firm and calm redirections. So for the book that your example gives is Tom, Finish Your Milkshake. So you may need to give them finger foods that they can eat while they're walking because they are manic. So for example, say, here's this fish stick that you can carry around the milieu with you, but you have to eat it. And then sleep, encourage them to rest during the day. And again, the low stimulation will help to promote sleep and rest. Hygiene, oftentimes these people will dress very flamboyantly, or they will dress incongruent with the current environment. So for example, in the heat of summer, they wear multiple layers of clothing, and we just try to help guide them toward more appropriate clothing. And then elimination. Fecal impaction may be a problem because of the patient's poor oral intake as well as their poor fluid intake. Teamwork and collaboration are important for patients who are in the acute phase of mania or delirious mania. The patient may be out of control. They may use power plays between and among the staff. And then we've already talked about splitting, which may be used as a way to distract staff and loosen the staff limits. So, a word about seclusion in the milieu. Seclusion may be required to control the patient during the acute phase of hyperactive behavior. It almost always includes immediate treatment with some kind of antipsychotic medication, for example, Haldol. However, when a patient is dangerously out of control, they may require seclusion or restraints. Just remember that in a psychiatric setting, the use of seclusion or restraints is very highly regulated, particularly if it's a behavioral restraint. There has to be a behavioral restraint plan in place. And there are very strict institutional rules and regulatory agency guidelines for the use of seclusion and restraints. Seclusion and restraint is always used as a last resort, and that includes physical restraint as well as chemical restraint. And even then, seclusion is used even more rarely than restraints. So the use of seclusion reduces overwhelming environmental stimuli, protects the patient from harm or self to others, prevents the destruction of property. The most important thing that I hope that you all understand about the use of seclusion for a manic patient or any kind of patient who's displaying behaviors is that seclusion is not a punishment. Unfortunately, I have seen nurses who have used seclusion as a punishment in order to teach patient correct behaviors or whatever the case may be. But seclusion should be used to help the patient regain control. It should not be used as punishment. Seclusion is warranted when documented data collected by the nurse and medical staff reflect risk of harm to self or others is substantial. The patient is unable to control their actions. Is when problematic behavior has been sustained and other measures have failed. So that is very important that you document everything else you've tried with the patient. So for example, all of those baseline needs on Maslow's hierarchy. You've toileted the patient, you've offered them food, you've offered them water, you've distracted them, you've placed them in a quiet area in the milieu away from other stimulation. You've given them, so that would be the verbal de-escalation. You've tried to talk them down. You've tried using medications, the chemical restraints. So, for example, you've given them a shot of Haldol with Ativan, and then they continue to be at a risk of harming themselves. And then, again, you put them in seclusion to help them regain control, not as punishment. So here's a quick question. When you hear the 3 to 11 shift report, you learn that one of your patients was aggressive during a manic phase and restrained with wrists and ankles, so 4-point restraints in the seclusion room. So prioritize your actions. In which order are you going to perform these actions? Okay, if you're not done prioritizing yet, feel free to pause it, but we're going to go through the answers here. The first thing you'll do is wake the patient and assess their vital signs. Then check each extremity for circulation. Take off those restraints, make sure they're not too tight. Make sure they do have some movement, because that's another thing that I've seen all too common, especially in the hospital, where nurses are not as familiar with restraints. For example, in a med-surg unit where they're using behavioral restraints, they completely restrict the extremity, and it should not be. They should have some play in those restraints so that they can at least move a little bit, but not so much that they can harm themselves or get the restraint off. So check each extremity circulation. So take the restraint off one at a time. Take, for example, one wrist off, check the circulation, make sure it's not too tight, put it on, and then move on to the next one. So you take them off one at a time and then replace it. Next, assess their mental status. And that can just be a quick mental status evaluation. Do you know where you are? Do you know what time it is? Do you remember my name? Who was your nurse on the last shift? Why are you in seclusion? So, just a quick mental status check. And then also ask them if they have any intention of hurting. Do they feel like they're more in control? A lot of times this is subjective, and the patient will be able to tell you that they feel better. Then we're going to check the electronic medication record for recently administered, scheduled, and as-needed medication. So are they due for anything? Do they have another Ativan and Haldol that they can have before you take them out of seclusion? That might be a good idea to help get them over the edge and back under control. And then finally, we're going to offer fluids, a snack, and toileting. And then we'll make that determination whether or not the patient is ready to be removed from seclusion. Maybe sometimes patients like to stay in there, so that's the other end of it too, that if the patient continues to behave, you can't use seclusion as a reward either. So the correct answer for this one then was B, C, E, D, and A. Okay, so here is a case study. Mr. Kwang, a 47-year-old single man, is admitted to the crisis stabilization unit of the Community Mental Health Center. The police found him in front of a movie theater, dressed in a robe, wearing a hat with peacock feathers, and walking barefoot. He was shouting, "This is my theater. I own it, and I own the whole movie industry. I have billions, billions, gazillions." His Axis 1 diagnosis, which they don't have Axis anymore, sorry, I should change that. His diagnosis is Bipolar 1. Most recent episode is manic, severe, with psychotic features. You are the nurse assigned to Mr. Kwang. What are your best initial interventions? So think about what Mr. Kwang needs. What does he need most right at this moment? He's just been admitted, he's in a crisis, and what are we going to focus on? And you can go back in the slides to answer that question. But that's something that you can do while you're studying. Okay, let's talk a little bit about medication treatment. Lithium is kind of the gold standard for treatment for bipolar disorder. It is still considered first-line agent. It alters the sodium transport in the nerve and muscle cells and inhibits the release of norepinephrine and dopamine. it does not inhibit the release of serotonin. So the patient will still have that serotonin level as normal in their pathology. Lithium is used for bipolar disorder. It is considered a mood stabilizer. It does require monitoring of the serum level. Therapeutic serum level is 0.8 to 1.4, with the maintenance level of 0.4 to 1.3. It is toxic at 1.5 to 2.0. Patients need to understand their maintenance therapy, so how often do they have to have their blood work checked? How often should it be adjusted? And then what are the adverse effects that they need to report? They also need to know about contraindications such as hypertension. Lithium carbonate is a salt, so patients who have hypertension should not take it. They also need to know what the long-term risks of lithium are. Table 16-5 talks about the side effects and signs of lithium toxicity, starting with early signs of toxicity such as nausea, vomiting, diarrhea, slurred speech, muscle weakness, whereas severe toxicity, that is serum levels 2 to 2.5, the patient will develop ataxia, serious EEG changes, blurred vision, clonic movements, large output of dilute urine, tinnitus, blurred vision, seizures, stupor, severe hypotension, coma, and death. So those serum levels need to be checked closely. Other drugs that are used in bipolar disorder are anticonvulsants. These are particularly useful in rapid cycling and dysphoric mania, especially valproic acid or Depakote, carbamazepine, which is Tegretol, and Lamictal. Those drugs are listed in Table 16-6 on page 297, including the major adverse effects. Remember that Tegretol has a black box warning for agranulocytoma and aplastic anemia. Lamictal can cause a life-threatening rash, which is Stevens-Johnson syndrome, and I showed you a picture of that earlier in the semester. Some anxiolytics and atypical antipsychotics that may be used include Klonopin and Ativan. Atypical antipsychotics that may be used if the patient is also suffering from psychosis, olanzapine, risperidone, aripiprazole, ziprasidone, and quetiapine. Those, especially the ziprasidone, quetiapine, and haldol, which is not haloperidol, which is not on that list, may also be used as chemical restraints. Other treatments that may help with bipolar disorder: electroconvulsive therapy, milieu management that we talked about, support groups, and then health teaching and health promotion. So in the presentation of Mr. Kwang, the 47-year-old man who's at the emergency department, includes blurred vision, muscle twitching, slurred speech, severe diarrhea. He shows you a card with the following medications listed: lithium carbonate, 300 milligrams twice daily, clonazepam, 0.5 milligrams twice daily for both sleep and agitation. So what are you going to do next? What do you think is your most appropriate action? Think about what the effects of his medication are. Some things that we would be concerned about here, especially with blurred vision, muscle twitching, slurred speech, and severe diarrhea, would be lithium toxicity. So we would want to find out, get more information. When was the last time he took his lithium? Has he been taking it as scheduled? Has he been taking it more? And then we would want to request a lithium level. What other actions do you think that you would want to do? Here on this slide, Mr. Kwang is transferred to the intensive care psychiatric unit. His medical records indicate a diagnosis of bipolar 1. The orders are to discontinue the lithium and add Lamictal to be titrated up to 100 micrograms per day. Why do you think they changed that medication? Okay, and one last question, and then this presentation is over. Mr. Quang is dancing under the overhead television of the crisis stabilization unit and taunting the other patients. He shouts, "I own the TV network, so they have to do what I say." And as Mr. Quang's nurse, what is your best initial intervention? Leave him alone and remove the other patients. Tell Mr. Quang that he has to obey the rules or he will be restrained. Medicate Mr. Quang with an anxiolytic and place him in seclusion. Calmly motion for Mr. Quang to come to you to the dining room for a snack. Okay, if you're not ready yet, you can pause it. Let's take a look at these options. Option A, if we leave him alone, that's not safe. And the other patients need to know that their rights and well-being are important as well. So it wouldn't be fair to them to make them leave the room, and it wouldn't be safe to leave him in there alone. So A is not a good option. B, tell him that he has to obey the rules or he will be restrained. Again, as I've stressed, seclusion restraints should not be used as punishment. So threatening a patient with them is not appropriate ever. C, although Mr. Quang may need both an as-needed medication and seclusion, that's not going to be the first thing that we jump to. D, distraction is the best initial intervention. Accompanying the patient to a place away from the other patients is appropriate. Now, he may not agree to go with you, but that should be our first intervention. So the initial intervention, what are we going to do first, is attempt to distract him. So that's the lecture on bipolar disorder. As you watch it, if you come up with any questions or want to discuss the case study or the critical thinking questions any further, just let me know. Otherwise, that ends this presentation.